I see that your first slide in the presentation is the intimate relationship between India and Egypt. We are very proud to be with us tonight, sir. Thank you so much for joining us.
Thank you.
Thank you
May
so
I
much,
start?
sir. Yes, please, sir. We have a moderator with us, one of your students, Dr. Hussam Al-Sayed. Professor
Yes.
RAGHAVA is the mentor of Dr. Hussam, and Hussam is very happy to be with you, sir. And many thanks to our moderator, Dr. Hussam Al-Ikshiri. Thank you so much, sir. May you start, please, sir?
Thank you. Good evening, and I'm sorry for the earlier hiccup. My sincere regards to Professor Hussam Al-Sayed and also to the young dynamic spine surgeon, Dr. Hussam Saad, and to Professor Gamal Hosni, the president of Egyptian Orthopedic Society. It is so nice that we are meeting and sharing our experiences in spine surgery. And this is a good cooperation between India and Egypt. Some of the oldest, and the earliest to practice the art of medicine. The Egyptian medicine and Indian medicine go back to centuries. And from there on, now we have come to the stage when we are now talking about advanced spine topics. I will go on to my first slide, and today I'm talking about spinal infection, the etiologies and strategies in management of these spinal infections. Now, we will go with the definition initially. Then we will talk about pyogenic infections. Then we talk about tuberculous infections of spine, which is extremely important to us in India, and I'm sure in most of the third world countries. And we will also talk about post-op spinal infections. We will talk mostly about our own experiences over the last 3.5 decades in managing these infections. Some of the slides I am showing you are the ones that I have shown you earlier in my earlier interactions and participations in the seminars, combined seminars. Now, what is a spinal infection? It is defined as an infectious disease affecting the vertebral body, the intervertebral disc, and the adjacent paraspinal tissues. That is a spinal infection. It could be pyogenic, like with Staph aureus, E. coli, etc. It could be non-pyogenic. It could be a fungal infection, or the most devastating complication of an infection after spine surgery. What are the predisposing factors for these spines to get infected? It could be malnourishment. It could be an individual who is immunosuppressed with a rheumatoid arthritis, a rheumatological issue, a diabetic condition, or perhaps suffering from cancers, old age, etc. Or rarely, it could be IV drug abusers. Most times, it is Staph aureus that infects the spine in the routine pyogenic infections. Of course, a variety of bacteria, including Streptococcus, Pseudomonas, E. coli, Klebsiella, and whatnot, can infect the spine. And that underlines the importance of identifying the organism to give the appropriate treatment. How do these patients present to us? It could be pain, it could be fever, it could be a localized tenderness, or sometimes diffuse tenderness, and there may be a neurological deficit. Sometimes they come to us saying that while turning in the bed, they get severe pain, and most times they may not have much fever nowadays, unlike in the past. Once a patient presents to us with pain and fever and tenderness, it's very important to do all the blood work that we do to evaluate and diagnose the condition. X-rays are very important, but as we all know, in the early stages, X-rays may not be helpful. MRI is the gold standard investigation. And when you do an MRI, it should involve not only the area of pain, but you should screen the entire spine. For example, if somebody complains of pain at the thoracolumbar junction, it's extremely important that we screen the whole of the spine so that we do not miss skipped lesions or infections of other areas of the spine. F18 bone scan is now routinely used, PET CTs, in diagnosing these infections. And of course, the gold standard is a biopsy and cultures. That alone will tell us which type of infection that is causing the problem to a particular patient. Once you do that, you have to manage. Most infections can be managed medically, as we all know. Surgery, of course, is when the infection cannot be managed by medical means. You have to, of course, go in for surgery to cure these conditions. So in the medical management, it's extremely important to identify the organism. And if there is an abscess, you must drain the abscess, and that becomes part of the medical management. As you can see here, there's a gentleman here, there's a lady here. She's a 29-year-old lady, and you can see the paraspinal infection. And this infection was causing her pain, and she actually came to us with abdominal discomfort. And an ultrasound revealed an infection in her abdomen. And then when we did the scans, as you can see here in the MRI, you can see that there's an infection of the spine. This was promptly drained by us, and then we put these pigtail drains to drain this abscess continuously. And of course, at the same time, we took a biopsy and sent material for culture and sensitivity. So all this becomes part of the medical management. Once you do that, it's always IV antibiotics. The way we do it, the minute we take samples for diagnosis, immediately we start them on broad spectrum antibiotics. And within 2 to 3 days, when we get the culture reports, either we continue with the same antibiotic if the bacteria is sensitive to the ones that we started with, or change to the antibiotic that is shown on the sensitivity panel of that particular organism. And it's always mandatory that you have to continue IV antibiotics for at least 6 weeks, followed by oral antibiotics for another 6 weeks. You have to immobilize the patient for pain relief of that particular part and give sufficient analgesia. You need serial blood tests and scans so that we can follow the patient not only by clinical examination, but also by blood tests and scans to see whether the patient is responding to the given antibiotics or not. So close watch must be maintained to make sure that there is the deformity, the infected vertebra are not getting deformed, and the patient is not developing a neurological deficit. This is extremely important. So it's very important that we do a close follow-up. It's not good to give antibiotics and say you come after 6 weeks, especially in the early stages. So when do you operate on these patients? What are the indications for surgery? For example, if the patient's pain is not responding to the antibiotics, the fever is not subsiding, or for example, his blood parameters are not coming under control, or for example, this MRI scans that we do are showing further increase in the abscess and discomfort to the patient, that is a failed medical management. And then you have to change your strategy. Or an impending neurological deficit, as you can see here, there's a foot drop. So once the patient is developing a foot drop or a neurological deficit, this means that that we have to do a lot more to treat this patient than just give antibiotics. And if the patient is developing a deformity, as you can see here, and that is again an indication for surgery, especially in the junctional areas of cervicothoracic spine and in the thoracolumbar spine. So what is your surgical strategy? What should it be? You have to debride like any osteomyelitis of the bone. This debridement must be very, very thorough and meticulous. You should excise the whole of the infected tissue. You should decompress the spinal cord and the nerve roots. you should, and at the same time, if there is a deformity, you should address the deformity and correct the deformity so that there is no compression on the neural elements. Once you do that, you should attempt a fusion so that when the spine, the infection heals, the spine is healed, the vertebrae are healed in their anatomical position. For this to achieve, either you have to do a posterior approach, an anterior approach, or sometimes a combined anterior posterior approaches. So you should be a surgeon well versed with the techniques of both anterior as well as posterior surgery. So as I said before, a pyogenic infection comprises of spondylitis, discitis, spondylodiscitis, pyogenic facet arthropathy. You may get an infection just in the facet joints or an epidural abscess. Epidural abscess is very common in the cervical spine, slightly lesser common in the thoracic spine, and even lesser in the lumbar spine. But epidural abscesses are notorious for causing neurological deficits, and you must act on these as early as possible. So any treatment of neurological deficit caused by epidural abscess is prompt surgical decompression with or without fusion. Especially if this epidural abscess is in the thoracic spine, it is very important to do a prompt decompression, because that could well lead to a myelomalacia and a permanent damage to the spinal cord. So if you see an epidural abscess, and if there's an early signs of neurological deficit, for example, an upgoing plantars or a slight spasticity in the legs, then obviously this means that you need to get in, operate, and decompress the spinal cord. So beware of epidural abscesses, especially in the thoracic spine. Don't procrastinate. Now you see here, this is a patient. You can see the spinal cord here. You can see the epidural abscess, destruction of the bone, and you see how that is compressing the spinal cord. And this patient was developing the early symptoms of compression of the thoracic spinal cord. So here we went in to the anterior approach. You can see the lung here. We did expose the spine and decompress the spinal cord completely from the front. And then we fused the spine from the front, and we turned the patient over and instrumented the spine to give a thorough stability to the infected area, so that with the debridement, bone grafting, and the stability provided by the instrumentation gives rest to the part and helps the antibiotics to reach the area and allow the infection to heal as quickly as possible. And the instrumentation would help us also in mobilizing the patient. Now, this is a patient who was coming to us for severe lumbar spinal stenosis, and we were treating him initially for conservatively, but when but his problems increased, he was developing severe spinal claudication, and when we posted him for surgery, about a week before, he developed infection of his kidneys, pyelonephritis, and later on this spread to his spine, and as you can see here, there is a decreased intervertebral disc space, and the patient was developing infection, and he was slowly losing power in his legs. We promptly went inside, decompressed the spinal cord, as you can see here, and then we instrumented the spine. As you can see, we also at the same time treated his spinal stenosis by a laminectomy and decompression of the spinal cord and roots. We contoured the rods, as you can see here. You need to contour the rods very carefully so that we get the thoracic kyphosis and the lumbar lordosis, and the infection was treated with appropriate antibiotics. This turned out to be an E. coli infection. This patient was treated with appropriate antibiotics for his weight, and then for about 12 weeks, and then he went on to have a good recovery. This is another X-ray that I've shown to you in the last talk. This is a patient who is about 80 years old, and she developed a collapse of the vertebra following a fall, and at 6 weeks, she had difficulty in walking. There was gradual loss of power in the lower limbs. She subsequently lost her bladder and bowel control, and in 12 weeks, she became a paraplegic, and she had a chest infection going on at the same time. Now, this is her MRI picture. This is a very old pictures, and you can see the paravertebral abscesses. And here you see this is a completely waterlogged right lung. So we went in from behind. We put these pedicle screws. They were absolutely loose in this 80-year-old lady. And because of the waterlogged lung, the anesthetist was not happy for us to use cemented screws or to use cement augmentation of the pedicle screws. He was worried about embolism from these screws to the lung. So we had to change our strategy as the screws were loose. So there was no good purchase. So we did this Herschel rectangle and sublaminar wires. So we decompressed the spine from behind and we added this bone graft. And we knew that this was not sufficient in this paraplegic. So we did a thoracotomy in this patient, as you can see here. And then we went in, we excised the whole of the infected area down to the spinal cord, and we put a couple of screws here. That's the lung there. And we put a couple of screws here, debrided the whole area, put a cage here, as you can see, because bone graft was not supporting this very osteoporotic bone. This was stabilized with the screws and rod from the front. And this was the posterior instrumentation that we did from behind. This is a lateral view. As you can see, this patient gradually recovered. And in about 8 to 10 weeks, the patient was able to regain the strength. And we were very fortunate. And so was the patient at that old age of above 80 years. She could regain her neurological function, and she started mobilizing, and she became a complete walker from a non-walker. So this is an instance where she had a pneumococcal infection of the spine from her chest infection. Now, this is a very interesting case. As you can see here, this is a patient that was operated for a discectomy and spinal stenosis. And she presented later on with infection of the spine. And this turned out to be a very rare Aspergillus terreus infection. This was extremely rare presentation of infection from a fungus. This fungus is extremely rare, and very few case reports are available in the world. And this usually is an industrial fungus and present in wet areas and construction sites. So always when you send samples for culture and sensitivity, don't forget to send a culture for fungus as well. So luckily we were fortunate that this grew this rare fungus, and we treated her for a year with antifungal agents. We referred her to our infection control specialist, and almost, as you can see here, this is in 2019, and in 2022, we are closely following her up, and fortunately, she's doing very well. Now, those are the fungal infections of the spine. What about tuberculosis of the spine? This is rampant in India, and according to World Health Organization, an estimated 1.3 million people died of TB in 2012, and this is increasing. Now, previously we were told when we were medical students that this affects the malnourished, this affects the poor people. This is certainly not so, especially in South India. It is affecting the healthy and the rich. There's a significant regional divide in India as well as across the world. And so it's not only the poor people, it's not only the malnourished, but even a healthy patient who is well nourished and wealthy are suffering from tuberculosis of the spine. And in my practice, we have a lot of these people coming to us with TB of the spine or the pot spine or the cox of the spine. This is essentially a medical disease. Diagnosis is often missed because most times they present with vague back pain, and a lot of times they may not have any fever. As I said before, they may just have pain in turning, they may have stiffness in their back, and they may have slight fever or feeling of having a slight temperature, or they may say that we feel a bit warm. So the traditional or textbook descriptions of TB spine is not at all present in most of our patients. So when we see these patients, as I said before, for pyogenic infections, we do all the scans. We do the blood work, we do the x-rays, we do the MRI scans, and sometimes when we are in doubt, we do a FAD in bone scans, and then always we do a biopsy and send them for culture and sensitivities, and we treat them medically. As I said, it's a medical disease, but there are times when the disease is not responding, then we have to operate. As I've shown you before, this is again an anterior approach we did a long time ago. And then we put bone graft, we debride it. Now here you can see the lung there. That's the diaphragm. And that is the dura, the vertebra being exposed from the front. And you completely and thoroughly debride and decompress the spinal cord. And then you put the bone graft. As you can see here, there's a tricortical bone graft that is being placed. And then slowly the disease is treated with antibiotics, appropriate antibodies to their body weight. And then you can see here 6 years post-op, the infection has completely healed. Now, again, this is another patient with a cox of the cervical spine. As you can see here, this vertebra is destroyed completely. There's a compression of the spinal cord, and the patient was developing early signs of neural compression. And we went in from the front. Again, as you can see, we expose the cervical spine, and that is a dura inside, thorough debridement, washout of the infected material. And then we put this, again, a tricortical iliac strut graft for stability. And then you put this plate to support the graft. And then that is a very strong enough to construct, enough to mobilize them on day 1 post-op. And then you treat them with appropriate anti-tuberculous drugs. And you see that gradually the infection subsides and the infection heals with appropriate anti-tuberculous treatment. In our hospital, we always give for 12 months of anti-tuberculous treatment, depending always on culture and sensitivities. Here's another patient. You can see here, the patient is developing a deformity in the thoracic spine. There is a prevertebral abscess. It's encroaching into the spinal canal. And there is a kyphosis that she was developing. And again, this requires a thorough decompression right up to the spinal cord, to the edges of the spinal cord. You have to be very careful in the thoracic spine because thoracic spinal cord is very sensitive and unforgiving. So you have to be gentle. And once you do that, you stabilize with instrumentation and then give the anti-tuberculous drugs. And they do very well with thorough surgical decompression and instrumented fusion of the spine. Sometimes in countries like India, the patients present very late. You can see the immense abscess and compression just below the brain from C1 down and see the significant compression on the spinal cord. This is some sort of an emergency as the patient was losing power in the legs. And you can see here, there's a complete destruction of the C2 vertebra here. And it's the destroyed vertebra is compressing the spinal cord because it's, and you see it's a very unstable situation. You can see here, there's a significant mobility of the vertebra and compression on the spinal cord. In the good old days, we used to use these sublaminar wires posteriorly on C1, C2 and decompress the spinal cord in the front and back. Today, of course, sometimes we use this technique when the bones are very osteoporotic. However, most times we do a thorough decompression. You can see the pus here. You take out the pus, decompress the spinal cord, and you get a thorough clean up job of this area, and then you stabilize the spine. But as you can see in these extensive infection, your purchase with anterior instrumentation is not sufficient. So you have to turn the patient around, and then you add a occipito-cervical fusion and bone graft the whole area after thorough debridement in front and back. And this way, you do an anterior as well as a posterior approach in a single sitting to get a good result. You see here another patient. You can see the compression of the spinal cord. This patient is in his 30s, and you see this extensive tuberculous disease compressing the spinal cord, and again as well in the thoracic spine. So he had both compression in the cervical spine as well as in the thoracic spine. And you see here, we decompressed the thoracic spinal cord and instrumented it. And then we also decompressed the cervical spine, all from behind this time, plated in the occipital area, the fixation was done. And then we extended the instrumentation to the healthy cervical spine. So we did a single stage thoracic as well as cervicothoracic decompression instrumentation and decompression of the cervical spinal cord and fusion. So this sort of surgery is required to get a good result and free the patient of this the tuberculous disease of the spine. Another patient with this infection in the thoracolumbar junction, again debridement instrumentation, this time all from behind. Today, most times we go all from behind and do an anterior debridement as well. In the thoracic spine, we cut the rib and then we go to the front of the vertebra from the side. Sometimes we have to excise 2 ribs and then we can put a cage from behind, or we can put bone graft and then debride the anterior infection, and at the same time instrument the spine from behind. In the lumbar spine, it's much easier because there's a lot of space and the cord is not as unyielding as in the thoracic spine. So you can gently retract the cord and then debride from in front of the spinal cord and instrument the spine. What happens if you don't treat them early or if you don't treat them well? You see here, this child was not treated well. And at the age of 17, you see the cervicothoracic kyphosis. So it's extremely important that these patients who come to us, especially in the children, it's very important that you treat them adequately. And now we have a risk of, we can predict which patient is going to go into a deformity. So we have enough literature on this. So we need to aggressively treat children with this tuberculosis of the spine. And as you can see here for this cervicothoracic compression, this patient was losing power in the lower limbs. You can see the cord edema here at the cervicothoracic junction. These are dangerous situations. So here we went from behind and then we instrumented the cervical spine and stabilized the cervicothoracic spine. And then we went and then decompressed the spinal cord all from behind. And you can see gradual cervical lordosis and thoracic kyphosis was established. And fortunately, this patient, this is actually the lady came to us around the age of 26, and she went on to do well. And we have been following her up for a long time. This is a patient from 2019, as you can see here. Now, another child with thoracic kyphosis, again, not treated adequately during childhood. This child was about 12 years old when they came to us. Here we use the robot to put screws in the spine, as you can see here. And then we instrumented the spine with the help of robot. But freehand technique is much easier and much faster than using robots, because you need a lot of experience using these robots. And then, as you can see, we instrumented the spine initially. We went in front of the spinal cord, excised the whole of that vertebra that was causing compression. We straightened out the spine and we decompressed the spinal cord. We removed the whole of that bone that was compressing from front, all from behind. And then you can see here how we could nicely decompress the spinal cord, instrumented the spine in this very small 12-year-old child. And this child went on to do well. Now comes the problem of drug resistance. Now, the World Health Organization in the Global Tuberculosis Report in 2013, the problem of drug resistance has been addressed by them. TB continues to evolve resistance to drugs. This is a major issue, and this has become a big problem. Drug resistance was observed for TB after the use of streptomycin. It's most urgent, difficult challenge now facing global TB control. MDR TB is present in almost 3.8% of new TB patients and 20% of patients who have had a history of treatment. So that's a significant number. So multi-drug resistant TB is caused by TB bacteria that is resistant to at least isoniazid and rifampicin. And extensively drug-resistant TB or XDR TB is not only resistant to isoniazid and rifampicin, plus to a host of other drugs like fluoroquinolones and the injectable second-line drugs such as amikacin, kanamycin, and capreomycin. This has become a big problem now. Why is this resistance? Why is there is increased continuing spread of resistant TB? Because of the weak medical systems, especially in underdeveloped countries. Incorrect treatment. Anybody who comes to the hospital, there is a common practice to give anti-tuberculous drugs without sending the material for culture and sensitivities. Ongoing transmission in communities and hospitals. So this is a big problem. Exposure to TB in institutions with a high prevalence of MDR TB. If the patients are kept in these hospitals where there are patients with multi-drug resistant TB, these patients catch that bug and they become multi-drug resistant TB patients. There's also the problem of community transmission. If current models indicate that in most countries, the majority of multi-drug resistant TB patients were infected initially with an MDR TB strain. So it is not that the bacteria is becoming multi-drug resistant. What's happening is that the patient is slowly acquiring resistance caused by inadequate or irregular treatment. It could be due to, as I said, nosocomial transmission in crowded hospitals. And repeated course of DOTS, short course chemotherapy should not be used, and you need a full course of at least a year of antibiotics for TB is made mandatory in management of these conditions. So as we know from this by Sung et al. Study, short course chemotherapy resistance to all first-line anti-TB drugs. So there is no role for short course chemotherapy. Even in India, if you take North India and I'm in South India, when we compare, the incidence of drug resistance is much higher in some states like Maharashtra and in the Northern India compared to Southern India. Southern India is slightly richer than Northern India and economically much better off in general. So perhaps that is one reason. And also the medical care is much more advanced and much more available compared to the far corners of Northern India. That is, of course, rapidly changing, and the medical help in India is rapidly advancing. In our own hospital, we studied 207 patients, and out of these, 109 were males and 168 were females. And this is the age distribution. And we did surgery in about 149 patients. And we did conservative treatment in 128 patients. And you could see here, with except 24 out of these, all of them had biopsies. These 24, all of them have come to us after starting anti-tuberculous treatment without biopsies. These were done elsewhere. And we found that our drug resistance is only 2.7%. That is less than what the World Health Organization is showing for in their own data from all over the world in 2012. So the drug resistance in Southern India is much less, and the average drug resistance in Northern India is about 10% overall. So what we do is obtain material for drug susceptibility testing at the very beginning of treatment. So when you take a sample, send it for drug susceptibility testing. Surgical intervention, if there is multi-drug resistant TB, we immediately go in and operate. Open debridement and percutaneous drainage of fluid collections is mandatory. Don't wait. You see here, you must drain these abscesses. And once you do that, as I told you before, put these pigtails, drain it out completely, do regular X-rays and MRI scans and blood work, and see if the patient is responding to infection. If not, go in, as in this case, thorough debridement from front, iliacus graft, instrumentation, and you can see how nicely the whole thing heals up with appropriate anti-tuberculous drugs. Always take the help of infection control specialists for these cases. Now, this is a lady from Bangladesh. She had 4 surgeries in Bangladesh, and she was not responding to antibiotics. And we operated on her 3 times. And then we could control the infection over a period of 4 years. She had sinuses, repeated discharges, and cultures were showing uh, resistant to different antituberculous drugs. But now in the last 8 years, her disease is cured, and she keeps coming back to us for follow-up, and she's disease-free. She has a significant deformity, but she is asymptomatic. So what is your strategy? Universal drug susceptibility testing should be mandatory. Test all patients for drug resistance at the start of treatment. This is very important so that you can identify patients who are resistant to tuberculous drugs, the first line drugs, and you can start appropriate treatment. Patients harboring MDR and XDR strains, they present a formidable challenge, and always involve infection control specialists at the very beginning of treatment. The last one on my topic today is post-op spinal infection. This is a nightmare. We do a very good operation, patient does well, we're very happy with the x-rays, and just a few days later, the patient returns with a problem. As you can see here, there could be a small wound dehiscence with a bit of leakage of blood and fluid that causes worry. And these post-op spinal infections are increasing. Why are these increasing? That is because we are doing longer surgeries today. That is because we are doing more complex surgeries today. That is also because we are operating on more and more older patients, and also we're operating on more and more elderly patients as well as those who are immunocompromised. Now, if you see here, what is the microbiology in these post-op infections? Mostly a single organism. Mixed infections are rare, 8.3%. Now, what is the incidence? It is about 0.27 to 11.9% overall. The type of surgery is the most important variable. For example, if you take lumbar discectomy, the average infection rate across the many centers of the world is less than 1% to max 2%, because mostly we operate on younger, healthy individuals. And most of these operations are short duration and less muscle stripping. But when you do slightly longer operations, for example, with instrumentation, the infection rates reach 6 to 8%, as you can see here. Now, if you have a graft that you take, the graft site infection is about less than 1%. If the patient has protein and protein calorie malnutrition, there is a chance of poor wound healing, increased infections, and there is immune suppression. So especially when you see patients with scoliosis, in our center, we always check the albumin, and the pre-albumin responds more rapidly to treatment and may be used as a measure of successful ongoing nutritional treatment. We give them hematinics, we give them protein supplements before they are subjected for these long surgeries. We do a blood count to see the total lymphocyte rate, the count, and make sure that patient is optimized before we operate on these patients, especially for long deformity corrections, etc. We tell our patients who smoke that you don't get better if you don't stop smoking. This is extremely important. The patients who smoke, they have higher incidence of infection. Patients with uncontrolled diabetes, obesity, rheumatoid arthritis, or potential risks for developing post-operative spinal infections. There are certain things that we can modify. Some things we cannot modify. If the patient is having a cancer or having spreads in metastasis, you can't do much about it. But there are risk factors that are modifiable. Poor general condition can be improved. Obesity, patients should be sent to dietitians to make sure that they are put on healthy diets and encouraged to lose weight. Active infection elsewhere at the time of surgery, especially urinary tract infection, especially in women. We have burnt our fingers by not checking the urinary tract infections. Today, in most patients above the age of 45, 50, and if they are diabetics, it is mandatory for us to do urine cultures so that any urine infection is present. We postpone the surgery, we treat the urine infection, make sure that the urine infection is completely cured with a repeat culture, and then only we subject them for spinal surgeries. This is also true of oral hygiene. Patients with bad oral hygiene are encouraged to improve their dental hygiene, and then we subject them for surgeries. There's a reason for why I am saying this. I'll come to that very shortly. Preoperative ICU stay, that is an increased risk factor, and blood loss more than 1000 ml is a factor for increasing the infection rates. So make sure that when you operate, you have a good team so that you can do a very quick surgery as far as possible, and so that the team, the exposure of the wound to the operating environment is much less. So duration of surgery more than 3 hours is again one of the factors that increases the infection rates. Now, risk factors for surgical spinal infection after spine surgery, 12 studies. This is a meta-analysis of 13,476 patients. Again, same thing, prolonged operative times, BMI of 35, posterior approach, more than 7 levels of operating on spines, diabetes, etc., low preoperative calcium levels, low preoperative and postoperative albumin levels. These are all potential risks for developing infections. Today, most of our patient gets protein supplements for almost 5 to 6 months after extensive spine surgeries. This, of course, does not apply to short spine surgeries. A low postoperative hemoglobin after a lumbar spinal fusion is again a risk factor in the study for developing spinal infection. So these are all factors that you must think and treat your patients appropriately and give them enough supplements post-operatively as well as in the immediate post-op period. Malnutrition is a major problem, especially in the developed countries. Malnutrition is not only protein calorie malnutrition, excessive is obesity is also a disease of nutrition. So 27 out of 28 infections in Mandelbaum studies, hospital stay occurred in stage surgeries. So to be very careful, hospital stay longer and infection rate higher when you do stage surgeries. Most times we do an anterior or a posterior approach, and after 5 to 7 days, we do the second stage, and these patients have a higher risk chance of getting infection. And he recommends a same-day surgery whenever possible. This is the incidence of post-op spinal infection. As you can see, lumbar discectomy up to 30%, cervical surgery, scoliosis correction is only 0 to 4%. And the infection rates in the adolescent idiopathic scoliosis is far lesser compared to infection rates in neuromuscular scoliosis. So this is very important. If your surgical duration is more than 4 hours, that again is a problem. So repeat surgeries, adverse neurological sequelae, high cost of patient care, sometimes death because of post-operative spinal infections, chronic pain, pseudoarthrosis. These are the problems if a patient develops infection after spine surgery. Now, how do you classify the surgical site infection? This superficial surgical site infection involves the skin and subcutaneous tissues. Deep surgical site infection goes deep to the fascia, discitis, epidural abscess, osteomyelitis, etc. As you can see, we also classify them early, less than 4 weeks from index surgery, late if the infection occurs 4 to 6 months after index surgery. Very late is approximately 6 months after surgery. How do they present? This is very interesting. They're all very good. They have an initial pain-free period. They do very well. They say that, doctor, thank you very much. I'm doing very well. And after a few days, they complain of severe pain. The earliest sign is this: they get severe pain while turning in bed. Whenever a patient complains of severe pain 10 to 12 days after your surgery, especially turning in bed, and if that radiates to buttocks, it's almost always a post-operative spinal infection. There should be a high index of suspicion. You do a thorough clinical examination. If this patient sends you a message on WhatsApp or calls you on the phone, ask him to come to hospital immediately. X-rays you should do, but may not be helpful in the early days. Do not procrastinate, act fast. If there is send the blood work, especially CBP, ESR, and CRP, very important. Send fluid that oozes out for culture and sensitivity if it is there. If there is a purulent discharge, intense back pain, recurrence of back pain after pain-free period, as I said, always suspect this. Send this fluid for culture and sensitivity. Most times the wound may not look like this. You may not get a redness around the wound. The wound may look like a normal post-operative wound. Be careful. If it looks like this, obviously, you must think of an infection. And if the dressing is wet, you must always think that this could be an infection. So as I said, I'm repeating again, most patients present 10 to 15 days after index procedure, and usually there is no fever, and there may not be signs of any infection. You must do an MRI scan to pinpoint the exact location and extent of infection. Always do CRP. The advantage of doing a pre-op CRP is when you do a post-op CRP, it rises very early. Let us say your pre-op CRP is normal, and after 2 to 3 days after surgery, if the CRP reaches its peak, so we know that there is a problem and we are alert to a possible infection. And the rise of CRP in the early days is very early, and it also falls rapidly by 17 to 19 days. So it will also tell us how the patient is responding to our antibiotics. The problem with ESR is it takes about 5 to 6 days to peak, and then it slowly comes down. So CRP is much more important. And as I said, imaging X-rays to get deformities, the implant cutout, etc., take a long time. And to see these signs of intervertebral disc space narrowing, etc., or erosions take a long time. Always do an MRI. Now, how do you know that this is an infection and not a routine post-operative change? Look at the intervertebral disc. If the intervertebral disc is white, in the T2, there is a hyperintense signal, then that means we are looking at infection. If along with that, there is a adjacent vertebral edema, and there is an abscess in front of the spinal cord, an epidural abscess. So an enhanced signal in the disc space, adjacent vertebral edema, followed by an epidural collection, is almost a sure shot sign of infection. If you're still not sure, do an F18 bone scan, and that will point out that particular area of infection. So this is what you should do after an MRI, if you're not sure on the MRI. If after doing this, take the patient for a biopsy. You must do a biopsy. If you do CT-guided biopsy, the yield rate is about 60%. If the CT-guided biopsy does not give you enough data or information or comes negative for cultures and on histopathology, immediately go for an open biopsy. Do not wait. As you can see here, this patient developed post-op spinal infection. So once you do that, you start broad spectrum antibiotics, wait for the cultures, and give appropriate antibiotics. As I said before, this is a patient who had developed infection in the sacroiliac area following a discectomy. This patient developed severe pain after a discectomy, operated elsewhere. She went to a pain management specialist, and he thought it was coming from the sacroiliac joint. He injected this area that got infected. So we sent this under local guidance for culture and sensitivity, and the report came negative. Patient was having severe pain, and we knew that a unilateral sacroiliitis is a 100% infection, but the CT guided, image guided biopsy was not yielding us a positive result. So we made a 1 centimeter incision, sent the cultures for routine cultures, and again the cultures came negative. So this is the time, this is what you should do. We did the multiplex PCR. This is an expensive test slightly, but this is what you should do if the cultures come negative. This is a 39-year-old lady. So once we send for the multiplex PCR, you get a big panel, and it will tell us which bug is causing the problem. And in this patient, see, it was negative to all these infections, whereas with Pseudomonas aeruginosa was detected, and we treated her for that with appropriate antibiotics, and she became all right. So you should give antibiotics sensitive to the isolated organism. Do not just give broad spectrum antibiotics, and involve physicians and infection control specialists. If they are not responding, as I said, drain the abscess, use pigtails to drain the infections, IV antibiotics for 6 weeks, followed by further oral antibiotics for 6 weeks, depending on the antibiotic. If the patient is developing, as I said before, neurological deficit, go in and debride. You must debride and excise the infected tissue. It should be layer by layer debridement. You should start from the subcutaneous tissue, excise thoroughly all of that infected area, decompress the spinal cord and roots gently and carefully, use curettes to gently ease the dead necrotic tissue, go slowly and meticulously, and then you do that, you attempt an infusion, and sometimes you can do most times with a posterior approach, but if need be, you can do an anterior approach or a combined procedure. What if you have implants? Do not remove the implants. Leave them alone. They add stability to the infected area. Give attention to appropriate nutrition along with the antibiotics. And as you can see here, this is a patient who developed infection at the graft site that spread to his implants. We did a thorough debridement early with bacitracin saline and dilute betadine solutions, opened all layers, left the metalwork in place, washed the grafts and left them in place, put deep and superficial drains, and we did a primary closure. And then fortunately, we went on to get a good result. Today, sometimes we use the vac. We thoroughly decompress and put vac for 5 days or sometimes longer. And that will give us most times a good clean field with healthy granulation tissue. So use of vac has become a worldwide phenomenon nowadays for contaminated wounds. You can see here, this is a patient who had a tuberculous infection. This was treated with an anterior posterior approach. There's a tricortical graft here, but this infection got controlled, but the patient developed a pseudoarthrosis here, as you can see. So we went in and the patient developed a kyphosis. So not only pseudoarthrosis, there was a localized kyphosis. So we had to correct the deformity here. So what we did, we exposed the spinal cord. As you can see, we did a laminectomy. We stabilized the spine with rods on one side. We went in front of the spinal cord. You can see this rubber drain, corrugated drain in front of the cord. And then we went into the pseudoarthrotic area, thoroughly excised this pseudoarthrotic area and filled it up with graft. And then we closed it. As you can see here, that space is closed, and then that is the immediate post-op period. So we thought we did a good job. We restored the normal lumbar lordosis and filled it up with graft. But 8th post-operative day, they were oozing. This patient was almost about 90 to 100 kilos in weight, developed fever of 101 to 102 degrees. We immediately drew cultures. It showed E. coli. And then we didn't wait. We went in, washed all the layers with betadine solution and almost 8 to 10 liters of saline solution. We retained the grafts, closed the wound over suction drains, and gave postoperative antibiotics. The pain decreased, the temperature returned to normal, And this is 1.5 year post-op. And now we have, this is an 8 year post-op, and you can see that the whole infection has healed, and she went on to do very well. Now, sometimes in situations like this, where there's a complete collapse of the anterior instrumentation, the cement got infected. Now, what do we do here? All the implants got infected. So in these situations, you remove all the infected material, remove all the vertebroplasty cement, thoroughly decompress. And then what we did here was to span the infection. We left this area alone, posterior decompression, removal of anterior instrumentation, left the spinal cord completely decompressed from 360 degrees. And then we put screws in the healthy lumbar spine and in the upper thoracic spine, because there was absolutely no hold in this 76-year-old lady. So we allowed the tissues to heal and then gave the appropriate antibiotics. And fortunately, she went on to heal well, and she did very well. She refused any further surgeries to correct, to stabilize her spine, and her infection settled down. So sometimes when you have situations like this, a discectomy that gets infected, you can always, sometimes either you can do a thorough decompression and debridement of the infection, or you can also add these screws and do intervertebral grafting or a cage, and then you can give appropriate antibiotics. So a post-op disc infection can be treated with a thorough decompression and instrumentation, and this will do well. The last part of my talk, sorry to take more time, is the resistant pyogenic infections. There is an increased incidence of deep post-operative infections, as I said before. And today, world over, more cases of gram-negative bacterial infections are being reported. This is contrary to what is taught and written in literature. So we're always told that it is a gram-positive bugs, but a lot of infections are now gram-negative. We studied retrospective study of 600 surgical patients in our institute. We included all types of spine surgeries, and when we reviewed the series, we had males 220 and females 380, total cases 600. This is the age distribution, 394 out of 360. You can see were in the 50 to 70 age group. That's the distribution of males and females. And we had, you see, this is the normal patients. This is the gram-negative, a gram-positive, and as I said, one fungal infection. Now, these are the various infections that we found in these patients. As you can see, the risk factors in our series, there are 3 patients with no risk factors. There are about 4 patients with instrumentation more than 4 levels. 12 patients were very obese, more than 85 to 90 kilos, and diabetes was again a significant factor. You can see this, our patients, E. coli was the commonest bug, and almost always it was in the urinary tract that was causing the problem. Initially, we were used to put this vancomycin powder to prevent Staph aureus infections. We stopped doing this because we thought that by putting vancomycin, we were actually causing maybe a gram-negative bacteria taking over and causing problems. And today, when we culture the gram-negative bacteria, very few of these bacteria are sensitive to a lot of drugs. Mostly they are sensitive to only 1 or 2 drugs. So that is a big problem. So these gram-negative bacteria are sensitive to very few drugs. One of the reasons that we think the cause for increased gram-negative infections in my unit perhaps is because of a lot of poultry being fed on colistin. Hyderabad is, my city is one of the big centers for poultry in India. And we have misuse of antibiotics in sheep and cattle. And when we consume their products, perhaps that is also transmitting the bacterial resistance, antibiotic resistance in our bodies. This is to be proven, of course. And also the gut, because of the decreased amount of the good bacteria in our gut, perhaps that is also adding to the problem. So as I said, today world over, more cases of gram-negative bacterial infections are being reported, and most of these bacteria are resistant to a lot of antibiotics. So all 18 patients recovered. All of these patients had repeat surgeries. Only 2 of these 18 patients required long-term follow-up and implant removal. We are still following them up. So to conclude this, gram-negative organisms are resistant to most antibiotics. There is limited published data on effective treatment regimen. Oral medication from gram-negative infections are limited, and IV treatment is expensive to the patient, and a lot of days of staying in the hospital adds to the overall cost of the patient. So surgeons need to be aware of this new phenomenon. Spine teams better than solo surgeons. I advise all of you to work in teams as spine surgeons, because with a team, you can do the surgeries much faster, and the team is there to look after the patients, and in a busy practice, so that the patients are followed up carefully and identified if there's an infection at the very early stage. You need a well-equipped and strict theater discipline. This is very, very important, and I don't need to emphasize on this. Educating patients and doctors about misuse of antibiotics. This is a responsibility. We know that there are more than 6,000 deaths world over on antibiotic misuse. I'm sure it's a lot more than that. So this is what we need to do as senior surgeons. Not only educate the patients, it's very important to educate our doctors not to give antibiotics for every cough and cold. And this is very important, so that when these patients require surgeries, be it spine surgery or any form of surgery, there is a good chance that if they develop an infection, they respond to antibiotics, and we don't have the problem of superbugs, etc. To conclude, early diagnosis, very important. Do a thorough, full radiological investigation. Always establish the diagnosis. Do appropriate medical treatment. Patient not responding, go in for surgery. Do not procrastinate, and do not give empirical antibiotics. Always, always identify the bug and then give exact weight, by the age and weight, antibiotics for the appropriate time, so that you get a good result after your treatment. I thank you for your patient hearing, and I sincerely thank the Egyptian Orthopedic Society, the Benha University, and especially to Professor Mohammed El Saab, with whom I have a very lovely relationship, and I'm sure we continue to have this relationship in future years as well. Thank you very much.
Thank you so much, sir. Thank you so much to Professor Raghava for this very, very interesting presentation. From your presentation, sir, I see that the pre, the intra, and the post-operative conditions, and even the infecting organisms are more or less similar in India and in Egypt. And this gives us the importance of cooperation between the Indian Orthopedic Association and the Egyptian Orthopedic Association to compete infections, maybe fellow exchange and doing online and physical presentations between both countries. This can help to compete infections, sir.
I totally agree with you. I think we should take it up now that the COVID pandemic is over.
Yeah.
And travel restrictions are over. I think it's very important. We have to establish that it's very important that countries like Egypt and India, which led the world a few centuries ago to come back to their glory and get the best of medical treatment. We taught the world, and it is time we cooperate and teach the world again the good medicine.
Sir, we will start, please. We will collect some questions for you, sir. And may I start with a question, please? I have 2 questions for you, sir. First question is, when do you decide to make the fusion by instrumentations after infection? Do you wait for a time elapse since the infection and the introduction of the instrumentations, or you are guided by the serology and the infection profile and the cultural sensitivity, when you are not afraid of flaring up infection by the instrumentation?
If there are two types in this, in tuberculosis of the spine, we have no problem because it is a much easier disease to deal with.
Yeah.
The problem comes with spinal infections.
Yeah, pyogenic. Yeah.
So if there is a fungal infection, we had a few candida infections. It's very difficult because if you put in instrumentation in fungal infection, that causes a huge problem. So you try to avoid instrumenting fungal infections of the spine as far as possible. Then comes the problem of pyogenic infections.
Yeah, yeah.
If it is Staph aureus with a good bacterial sensitivity to a good amount of drugs, then there is no problem. You can go ahead and instrument the spine. For example, if you get a gram-negative bug, which is just responding to colistin, for example, in an elderly patient, it is not a good idea to instrument them because you have just one or two drugs to play with. These are all general rules. If there's a significant deformity causing compression of the spine, and we need to correct the deformity at the same stage, that's a different scenario. If the spine is more or less stable, and if it's a gram-negative infection, and just one or two bugs it is sensitive to, then I would wait, treat the infection, and then go in second stage.
Yeah, thank you, sir. The second question for you, sir, is when do you decide to do anterior fusion by anterior instrumentation, posterior fusion, or combined anterior and posterior fusion by instrumentation?
In the early days, I'm basically an anterior surgeon. We were all taught in our times to do a lot of anterior surgery. So nowadays, most of the surgery is in the thoracic spine. We do all from behind. So we excise the rib, or as I said before, and then we do most of the anterior surgery in thoracic spine from behind, and then we instrument from behind. In cervical spine, it's always, almost always combined anterior posterior surgery. We do a lot of anterior surgery in cervical spine because it's easy to access. We do a thorough decompression, and we do an anterior surgery. The problem with cervical spinal infections is the implant hold. You suppose if the vertebrae are very osteoporotic, you don't have a good choice. They have to turn the patient behind and do a combined procedure of anterior posterior. If the infection is all posterior, then in cervical spine, we go and do posterior surgery. Initially, we used to do a lot of the lateral mass screws. Today, we do a lot of pedicle screws. Again, this doesn't apply in children. We tend to still do lateral mass. And in slightly younger population or older population, we put pedicle screws. So lumbar spine, again, is mostly posterior today.
Thank you, sir. Dr. Hussam Said, you have any questions or any questions from our dear attendees?
Yes, I have one question, sir. If you prefer using bone graft, as I see in most of your cases, than cages, is that only for infection for some reason, or what? Or you prefer or in all cases of spine fusion?
The question is, when do I use a bone graft and when do I use an implant like a cage? Is that right?
Yeah, yes, an infection.
Right. If the spine is stable after debridement, we don't need to put a cage. We can just put a tricortical graft and supplement with instrumentation. If after debridement, the area is very osteoporotic and it is not healthy bone, very soft bone, when we put a graft, it tends to collapse. In those situations, we put a mesh cage and then we put with graft inside, and we also place graft around the mesh cage. In infections, you should never use expanding cages because expanding cages, in our experience, cause a lot of pseudarthrosis. So if the bone is strong enough after the end of debridement, then we put a tricortical graft. If the bone is not very strong, very osteopenic or osteoporotic, we tend to put a cage and supplement with instrumentation.
We have another question from Dr. Faisal. He was asking about vancomycin in local in the wound after spine surgery or gentamicin, and what's your opinion and what you use personally?
Personally, I stopped using vancomycin because I thought that that was encouraging. I don't have scientific evidence for that. But by putting vancomycin, as I showed you in the last 600 cases, we had more gram-negative infections than gram-positive infections. So maybe this vancomycin is the culprit. So I stopped using that. I used gentamicin. The reason why I use gentamicin is again because of the emergence of gram-negative infections. So I wash the wound thoroughly after surgery. We do frequent wound wash. I'm talking about the fresh cases, non-infected cases. And then I put the gentamicin 80 milligrams. If in culture, if I find that the culture has shown in a post-operative infection a gram-positive bug, which is responding to vancomycin, that's the only time I use vancomycin powder. So I stopped using vancomycin except in post-operative spinal infection, that too when the bug is sensitive to vancomycin.
Okay, one last question about your opinion and minimal invasive surgeries in spine infection, including thoracoscopy for anterior debridement and fusion with posterior percutaneous instrumentation. Is that enough for treatment of infection?
Oh yes, percutaneous techniques are very good, more than sufficient, but you need experience and you need training. So if you are well trained, then there is no problem. But again, you should be very quick because most of these infection patients are not very healthy. So if you take hours doing percutaneous techniques and debriding them, that's not a good thing. If you have a discectomy, for example, post-op discectomy, then if that gets infected, today we put a small cannula, or even with instrumentation, we put a scope, we put copious amounts of saline and wash it out in the post-operative spinal infections. So if you can do a fast procedure with minimally invasive technology, there is no problem. But don't take too much time doing those procedures because the benefit in infections is very minimal with minimally invasive spine surgery.
Dr. Sam,
We have
another question?
Yes, we have a question from Dr. Muhammad Sultan. You want to tell us more about, if you want to tell us more about multiplex CRP, CBR, okay. Test,
CRP test.
CRP test.
Oh.
Yeah.
See, the problem with ESR, which we have been traditionally taught, is that let us say the ESR is about 15 before surgery.
Yeah.
And post-surgery, it is 25. Now, we don't know. And every time you do a blood count, let us say the white blood count was 6,000 to 7,000. And post-op, it is 11,000. Now, we are not sure if this white count increase is because of the routine post-operative inflammation, and the slight ESR raise is because of the post-operative inflammation. If you do a CRP, let us say it is normal, and that raises very fast, that gives us a very good indication that maybe we are looking at an infection. So I strongly urge all of you to do CRP. It's not an expensive test for every patient who undergoes elective surgery. Suppose if your lab value for CRP is 3, for example, different labs give 1, 3, or 6. So whatever the technique of the lab test, if 3 becomes 10 in the 3rd or 4th postoperative day, perhaps you are staring at an infection. So that is the advantage of CRP. It raises rapidly. And when you are giving antibiotics, ESR takes a long time. So you will not know whether the antibiotic that you are giving is responding to the infection is responding to this antibiotic or not. If you are giving an antibiotic, the rapidly risen CRP is coming down fast. That means it gives us a good idea that the antibiotic that we are giving is working and that we could continue with that antibiotic. So it's a one good way, apart from, of course, the imaging modalities.
I think we have no more questions, Dr. Hussam.
Yes, that's
Yes. Finally, I would like to thank Dr. Raghava from Hyderabad, India, for his time, his precious time, and for his marvelous presentation. Thank you so much, sir. And I'm always seeking for more and more collaboration between the Indian Orthopedic Association and the Egyptian Orthopedic Association. And this represents the cooperation between two great countries with great history, India and Egypt. Thank you so much, sir.
Thank you very much. Always a pleasure. Good health, stay safe, and together we progress. Thank you very
so much, sir.
Very kind.
And best wishes for you and all our Indian colleagues. Thank you so much, sir.
Thank you very much.
Thank you so much, sir. Thank you. Have a nice time, sir. Good
day.
Good evening, sir. Thank you so much. Thank you. Have a nice time.